Hi, and welcome to the Curious Cardiologist podcast. My name is Dr. Sanjay Bhojraj, board-certified interventional cardiologist and functional medicine practitioner. In this podcast, I'm going to look at old problems in new ways. We're going to have a series of guests who are going to force us to challenge the status quo and rethink the way we approach health. Because I found in conventional medicine, we really just treat things, but what we need to do is focus on healing. So if that sounds like something that you like, if you're a practitioner, if you are a patient, if you're someone who's just looking to optimize your health, you found the right place. I hope you enjoy this episode. Hi, everybody, and welcome to this episode of the Curious Cardiologist podcast. My name is Dr. Sanjay Bhojraj, recovering interventional cardiologist, now working in the functional medicine space. And we are here today with Emily Sadri, who's just a fascinating person. We'll get into a lot of her background and training, but trained as a nurse wife and nurse practitioner and I don't know what a nurse wife is, but
a nurse midwife.
A nurse midwife is what I meant to say, but a nurse practitioner, became a midwife, and now focuses a lot on hormone therapy and metabolic disease and its influence on all of our health. So Emily, thank you so much for being here.
Thank you for having me. And I love that. I could say that I'm a recovering midwife as well. Still in me, but
still there. Yeah, it's still there, layers deep. But it's almost sometimes you have to deprogram yourself when you've been in the conventional world for so long in this space. So let's just start out. We'll just jump right in. Tell me a little bit about your journey from the conventional medical space where you're practicing before into what's morphed into a pretty awesome practice that you've got right now.
Yeah, thanks. So many years ago, I started my career as a nurse practitioner and nurse midwife. So I was delivering babies in a low resource setting in urban Cleveland, and really got into midwifery before I even knew that you had to be a nurse. So it's kind of an accident that I even ended up with a more official medical designation of nurse practitioner. And I really felt pretty burned out when I was approaching year 5 of practice. Simultaneously, while I was in school and in early practice, I had 4 children.
Oh.
So, that that may
Please tell me you had somebody else deliver them for you. You didn't.
I did. No, I did have midwives.
Yourself too. Okay.
I did have midwives, but I did have home births.
Okay.
Something I just knew was what I wanted, and would have been happy to deliver in the hospital if I needed that. But for me, it was the right choice. But I caught babies in the hospital, and I just felt this massive disconnect, not only in my own health. And it's interesting. One of the things that popped into my head as you were introducing yourself was, you may see this as well in your practice, that some of our hardest patients are physicians or nurse practitioners. Like, they're the people that are working in the system who probably got into it for really altruistic reasons, are just so beat down and so disconnected from their own health and so disconnected from the pillars of the things that we know make us most healthy, like good sleep, good fresh food, love and connection.
Just not having a nervous system that's fried all the time.
All the time, right? And I think more sensitive people are attracted to medicine because we want to help. And so we're even more susceptible, to the sort of lifestyle of it. So I felt myself very much cracking under that. I actually had gestational diabetes in my 3rd and 4th pregnancies, which to me made no sense because for all intents and purposes, I had a very healthy diet. I was active. I wasn't overweight, but metabolic issues ran in my family. And what I found was that the only thing that really helped my morning blood sugar, which was the only marker that was ever really off for me, was meditation and deep relaxation. That it didn't matter how much I restricted carbohydrate grams. In fact, like even being at like 30 or 40 grams of carbohydrates a day, which is extremely restricted for a pregnant woman, that didn't affect my blood sugar, but doing deep relaxation did.
That's pretty amazing. And the whole kind of thesis, if you will, of the podcast, The Curious Cardiologist, is looking at old problems in new ways. Mm-hmm. And exactly what you're saying is that I'm sure the conventional docs were saying, well, just don't eat sugar, reduce carbs. And that still had no effect, right? So what we need to do is connect the mind and the body and realize that there's something going on. And I think nowhere is that connection more sacred than while you're manufacturing a child, right?
Yeah, it was really eye-opening to me. And it was also, I learned a lot about sort of genetic type and sort of diet tolerance. Some people don't do well with high saturated fat sort of keto approach. Like, that is actually more pro-inflammatory. And I'm one of those people that actually does better from a glucose control perspective when I'm eating more whole grains and vegetables and much leaner proteins. I don't tolerate saturated fat as well from an inflammatory perspective. So again, things that just sort of weren't discussed, and that made me really curious and made me go, if I'm struggling this hard to be healthy, then I just didn't feel authentic in my work anymore. It didn't feel authentic to me to be helping other women be healthy when I was just constantly sort of lying every day about how I felt. So right after I gave birth to my fourth, I resigned from my position before going back from maternity leave. It didn't hurt that it was the middle of COVID and I had 3 other kids home from school. And, it was a time when people made big decisions, and that was my big decision.
It was I mean, I've got triplets, as probably our listeners have realized at this point, and I can't imagine 4. I would just fold.
But yours are the same age. That's craziness right there.
Well, there's I think there's a maximum number of stress humans can have. So I can't even imagine going through training and practicing as 4 kids. I mean, kudos to you. And I do think you're right. COVID was an interesting time for us, right? Because it made us, a couple of things, realize that we needed to slow down. Either we were forced to do it or the pace of our lives just kind of changed. And you're right. It allowed us to make some big decisions. So did you make the right choice in your big decision of leaving?
100%. And, the other interesting thing about COVID was that we probably had the same experience. We didn't see patients as much, right? The people that had to be seen every 2 weeks suddenly could go 3 or 4 weeks. All of our sort of medical model of what needed to happen changed. I just thought that was so interesting. It was maybe we don't need to stress people out as much, and we can we learned a lot about less is more during that time. And I was doing a lot of virtual visits during COVID because we switched to primarily telehealth, and I was pregnant. So I was sort of first on the list to take patients by telemedicine. Yeah. And I was I really like this. I like the fact that I can go to my kitchen and eat food that makes me feel good and be there for my patients. And it doesn't feel like so much stress to drive across town and all these things. So it was an easy leap. That being said, for people out there who are providers, I'm sure you have providers listening to your podcast who are thinking about taking the leap. Just my little plug would be start before you're ready, because I didn't have a plan. I'd never had a business before. I didn't know how to set up an LLC. I didn't know anything, but I really trusted. And I think many healers will resonate with this, that if I made the right decision for my body and my health, it would lead me down the right path. And that the healthier that I became, the better I would become, and that it would all unfold. And it did. I mean, it really did. I started out by just doing home visits, and I would do your pap smear and your breast exam and your blood draw in your home. And then a few weeks later, we would meet via Zoom to review your results. And I loved that because it was midwifery, but for primary care. It was really meeting people where they were.
Well, and I like too kind of the hybrid model, because when I was doing telehealth visits in cardiology, even the background of the patient, gave me some insight into what their home life was like. I'll never forget. I was on a kind of 2 visits. Number one, some guy, we're doing a telehealth visit and he had his video off. And I said, I'm sorry, sir. Really, it's, it helps me to have video on so I can see and whatnot. And he's driving, right? And I'm like, you got to pull over to the side of the road, right? So I think that kind of speaks to how aggressively people multitask and try to get so many things. And that drives a lot of our sympathetic dominance, as I'm sure we'll talk about. The other one that was absolutely hilarious was I was talking to somebody, and then all I see this kind of white kind of column kind of rising up. And I'm like, wait, is that an ashtray in front of your computer? Are you actually smoking
while you're
on a cardiology visit? Come on, dude. At least put the ashtray behind the screen so I can't see the smoke. But I didn't even know that patient smoked. And I've got a pretty sensitive nose, as probably most healthcare people do. So, I mean, even if you had a cigarette 2 weeks ago, I could smell it. But it gives a lot of insight into it. But I also think a great part of it was, in a sense, people took a little bit more ownership of their health. I don't know if that makes sense. Like people realized, oh, you know what? I need to do these things a little bit more. And I don't just offload everything to the doctor because I don't know when I'm going to see him or her, whoever my healthcare team person is. Maybe I need to take a little bit more control. And we saw that, I not tons of opinions on the pro or anti-vax kind of side, but people were more concerned about what these treatments, how it affected their own health. Right. And I think that was kind of a weird way, a good thing. And to your point, after I left, my health improved so much as well. So for the practitioners, I realized that I was on track, as I approached 50 to have my own heart attack as I was treating everybody else's heart attack. Right. So I think that for the practitioners listening, we have to be aware of the toll that our careers take on ourselves, right?
Yep.
So I think
Yeah.
that's a hugely important lesson.
Totally. I think during COVID, we saw firsthand that people who were more unhealthy, especially from a metabolic standpoint, were more likely to die from COVID, right?
Yeah.
And that was a real reckoning for a lot of people, that there was this threat and there was this, now I'm in my house and I'm kind of face to face with like how I'm feeling and what my risks are. And, for better or worse, that was a wake up call.
Yeah, no, absolutely. Absolutely true. Well, why don't we kind of push into kind of what you're doing nowadays? Because I'll tell you, as a cardiologist, and I did my functional medicine training through IFM, and I'm actually going through A4M right now. Hormones were something that I would never have wanted to touch with a 10-foot pole, to be honest with you. I think that even, men, it's much simpler in men than women. You've got testosterone, kind of essentially that's it, right? Women, you've got all these cycles and things and all these kind of craziness, but I didn't really appreciate hormone replacement therapy as a cardiovascular therapy, right? Which more and more, I think the literature is starting to support. And I know that's a lot of what you talk about in your practice as well. So let's kind of, how did that evolve through your training as an NP and then as a midwife? How did you get to hormones? And then specifically, how did you kind of link that to metabolic disease?
Yeah, I love those questions. So when I was in school in the early 2000s, I had a minor in public health. So I had a lot of epidemiology, and my entire epidemiology course was on the WHI study, which some of your listeners will know is the, large study that came out in 2002.
It's like the ultimate medical facepalm.
Yes, exactly. And that was the holy grail. I mean, we studied what a well-designed study it was. And so we also concomitantly in my clinical training learned that basically hormones were off limits. SSRIs are the number one treatment intervention for symptoms of menopause. And we spent 90% of the education was learning about birth and delivery and prenatal and postpartum. And then the other 10% was make sure to give people calcium, treat them if they have high cholesterol, give them baby aspirin, and screen them. Like that was really sort of health after 40 in a nutshell. And and it's crazy. And if you take the Menopause Society exam today that will, board certify you as a menopause trained clinician, most of the questions are still on that primary care stuff. It's like, at what age do you do this? And because we didn't have tools. And so the only thing we could do was say, like, make sure to screen them well. The wild thing, and this still persists, I think, in both sides, on the conventional sides and the inside and the integrative side, is that midlife women, their health really falls off a cliff. It's different than for men, right? For men, they are more likely to have a heart attack when they're younger, but women far surpass male counterparts after the age of 50 in terms of cardiovascular disease risk, and cardiovascular disease is the number one killer of women. But no one is making the connection that the loss of estrogen dramatically accelerates that risk.
Absolutely. And I think one of the earliest signs of, I guess, perimenopause that cardiologists see all the time is that LDL bump out of nowhere, right? Yeah. Like in retrospect, I would have so many women, this is before I did my functional training, and, their LDL would just jump 30 points. And I'd be like, oh, what are you doing? Are you eating differently? Are you not exercising as much?
Yeah, made them feel guilty, like every good doctor does.
It's the when the doctor doesn't know what's going on, we just blame the patient, right? Like, that's just kind of how it is, right? So it's like, what are you doing that you're not following my recommendations? But in retrospect, I think cardiologists are actually probably front line in detecting when perimenopause happens. And that's why I think it's so important for us as cardiologists, functional cardiologists, to at least recognize and then refer if you can't do it yourself, right?
Yeah, 100%. Yeah, estrogen has a direct impact on the liver and the way that it decides to sort of bring back LDL from circulation, in the way that it produces HDL. So it downregulates the production of HDL. Estrogen influences insulin sensitivity. So as we become more insulin resistant, right, our triglycerides go up, visceral fat deposits as estrogen declines. So it's just this dramatic cascade. And there is, of course, an independent metabolic sort of aging or inflammaging or sort of fall apart, I like to call it, that happens. And I know this because it's really interesting in our practice. One of the methodologies of HRT that we do is called like a sort of dynamic or precision HRT, where we sort of mimic the menstrual cycle. And we do this sometimes with women who have premature ovarian insufficiency, who are like 25 or 28 years old, don't have a cycle, or amenorrheic, anovulatory, women with PCOS, who are very severe cases, like in their early 20s, who have an estradiol level of 20, right, and an FSH through the roof. And we could get into all the reasons why that happens, because it's a bad situation, right? How many women are sort of have hormonal fall apart in young age, and all of the root causes of that. And part of what we do while we're trying to work on those root causes and get them healthier is we'll put them on rhythmic hormones to replicate their cycle. And the fascinating thing is that these women will come in and they'll present like 50-year-old, 60-year-old women with metabolic issues, right? They have A1C of 5.7, they have, high LDL, all the things. They have the whole syndrome. And as soon as you put them on cyclic hormone therapy, everything completely normalizes, like within 3 to 6 months. Like it's profound.
Well, it's the body functioning as it's designed, right, to function. And one of the amazing things, and I'm not a women's health person. I mean, meaning I don't practice in women's health, but I have a lot of women in my life, my daughters and my wife. And I think back to kind of the nonsense of hormone replacement therapy in terms of like birth control pills and how easy like it is for like young girls to get birth control pills for like acne and painful periods and seemingly, I don't want to belittle this, but not kind of more symptomatic or life-threatening things. But yet at the same time, when you have women in an older age group, it's like pulling teeth because of the WHI for them to get the therapies that they actually need to reduce their cardiovascular risk, improve cognitive function, and improve quality of life, right? So I don't know. In a former, like when I was in med school, I think we were talking earlier, I loved OBGYN. I loved delivering babies. My mom told me don't go into it because guys aren't supposed to do OBGYN. I was like, fine, I'll just take the easy route and be an interventional cardiologist instead. But I never understood the conventional kind of mindset around, and I came out of training right around WHI. So, not as intimately involved with that study as you are probably, certainly, but it didn't make sense. Like, why is it okay when we're younger, but not older when we really need it?
Totally. Well, and you could argue easily that the birth control carries more risks than transdermal bioidentical estradiol. The WHI, for those that don't know, was done on Premarin, which is a synthetic conjugated equine estrogen. So it's very different in molecular structure than human estrogen. It was also taken orally. And it's really important for your audience to understand that oral forms of estrogen, whether synthetic like birth control or Premarin versus, or just being bioidentical like oral estradiol, still carry higher risks from a cardiovascular perspective than transdermal estrogen, right? They upregulate clotting cascades. They have to go first pass through the liver. So they, do increase VTE risk, whereas transdermal estrogen has not been shown in any study to increase VTE risk whatsoever.
Yeah, I think there's a lot of confusion, and that might be why it's so difficult as a cardiologist for me to want to step into this, because the studies are so kind of variable, right? Like not just in terms of dosing, but route. And I didn't really understand before I started doing all this of, bioidentical, what that really meant versus synthetic and I mean the three estrogens, and estrogen is a cluster of hormones, not just one thing. I mean it's requires, I think, a lot more specialized knowledge than people realize. And that's why I think when women are concerned, like really reaching out to a hormone specialist or someone who focuses in menopause, I think you can never have enough menopause specialists, I think, because it's so complex.
100%.
But there's so many people, I mean, women that suffer through this.
Yeah, and only about 4% of the eligible population is currently on HRT. And there are tens of millions of women, right, who are suffering and who, maybe they know that their symptoms are menopausal. Maybe they're just suffering from metabolic fall apart and they don't understand the connection whatsoever. And there's only 7,000 menopause providers out there in the country. We're grossly, underserving that population.
Wow.
We really have a big need to be met. So I really think that every provider, including you, who works with women in midlife, should know how to prescribe basic hormone therapy, especially because it's going to change your outcomes. I mean, we see dramatic changes in LDL as soon as we initiate estrogen therapy with people. It's astounding. I see people's A1C decline with no other intervention except for estrogen.
Yeah, cardiologists are like toddlers in that way, is we only care about what we care about, right? So, when you tell your toddler to eat vegetables and they don't want to, but then you say, do it, your brother is doing it, whatever, and then they do, right? So I think once we start talking about cardiovascular benefits, cardiologists, our ears perk up and say, okay, what can I do to take better care of our patients? So why don't we talk a little bit about kind of, as you mentioned, so you've seen improvements in LDL, improvements in HDL, let's kind of run through, let's maybe back up and say, all right, what should I recognize as a cardiologist or as a primary care doctor or healthcare practitioner, NP, whoever it is? I'm looking at labs, I'm looking at lipid tests, which I think, like I said, for me, it's the canary in the coal mine when we start talking about hormone health. But when is it appropriate to get on therapy, meaning bioidentical hormones? When should I refer out? Like, what does that, maybe run me through that process?
Yeah. So I think these are great questions. And I think foundational things to know are that the earlier that we intervene, the better. So that's one thing that we see in the literature. It doesn't mean that people can't be started on HRT after a certain age. I started my mother-in-law on HRT at age 75. She's doing great. So it's really, takes personal evaluation. And some of that data around like not past 10 years past menopause still comes from the WHO. The average age of women in the WHI was 63. So they were mostly more than 10 years post-menopause. They were also a more unhealthy population.
And when is menopause supposed to happen for those of us who don't know?
So the average age in the US is about 51.
Perfect. Okay.
And I don't even love the designation of menopause because so many people will never even be able to know when they haven't had a period for a year because they've had an ablation or a hysterectomy, or maybe they're using an IUD. So it becomes this very sort of this moving target of like, I don't really even know how to determine that. And
it doesn't show up as a Google Calendar reminder.
No. And perimenopause lasts for 10 to 15 years. And most of the problems are happening beginning in perimenopause. And that's when you really need to be looking out, even before there's any changes to the menstrual cycle. We see in our clinic that the typical first symptoms are mood symptoms, and these often get written off because women in this phase of life are busy. Like me, they're caring for elderly parents, little children, they're growing their careers. So it's normal that they're exhausted and tired and stressed, and maybe their hair is thinning and they have a shorter fuse, and maybe their PMS is worse or their sleep is disjointed, but there's a million things to blame that on. And particularly their PCP or OBGYN is not making the connection for them that it could be hormonally driven. The other thing that we see though is that these women are starting to gain weight. Their LDL is going up. So women from the age of 40 on will gain about 1.5 pounds per year, doing nothing different with their diet or lifestyle.
And part of that is probably not just gaining fat, but also losing muscle.
100%
as well, right? So we have to, like, whenever we talk about weight, I always kind of focus on, rather than weight, body comp, right? Yep. So body composition starts to change. Visceral fat, I would assume, would increase as well.
Yep. And this is a red flag. So if someone says like, it's just weird, like I haven't gained any weight, but like my pants don't fit and my belly, like what is this belly fat? Like that is not to just be written off. That is an increase in visceral fat that is directly related to the loss of estrogen. But it's also the point that I was making earlier is that although estrogen is driving metabolic decline is also happening independently of estrogen decline. Like when we replace hormones in older women, it doesn't make a change, right, in a woman's metabolic status. There is also independent metabolic aging that needs to be addressed, right? We have to be thinking about sort of a pro-metabolic diet, a different sort of...
Well, like toxicities and lifestyle and endocrine disruptors.
And also just think like the beta cells age in the pancreas, right? Like
true.
These mechanisms by which we maintain homeostasis are all also aging.
Right, truth.
There's just cellular aging. So we are just not as efficient at dealing with energy and energy distribution. And so all of those things, right, need to be independently addressed and part of like a cohesive whole. Estrogen is one part of it, but I rarely see dramatic changes from a metabolic standpoint with estrogen alone. Like we can't treat it in a silo.
I mean, one of the things that frustrates me so much about hormone replacement in general is, well, number one, that not everyone's getting it that needs it, right? But number two, people are going on hormone replacement therapy without really treating all the underlying issues that are happening, right? Like you need to get your metabolism in balance. You need to get your stress right and your sleep right, because if you are stressed out all the time, not sleeping, eating like garbage, correct me if I'm wrong, but there's not enough surface area of the skin to get transdermal estrogen in there to help, because we're putting, these hormones that are trying to do their best into a system and a milieu that's already so out of balance that you can never really balance it. And I see that with guys all the time that, in my cardiology practice, I tend to see a lot of men, and, they always asking me about going on testosterone. And I'm like, dude, yeah, I mean, it'll help, muscle mass and all these things, but, you're eating like garbage. You're not sleeping. Your lifestyle is so
taking in like 500 milligrams of caffeine.
Yeah. I mean, yeah, like these monster, like these energy drinks and all these things. I'm like, unless you get that the rest of the house in order, right? Hormones are, it's trying to mop up the ocean, right? It's like a drop in the bucket. It's not going to do much for you.
Yeah. And you really can age healthily without HRT. I think it is much harder. I think that a really healthy woman, in my experience, always does better with the addition of HRT. I would say there are some exceptions, like people who have, a lot of MCAS symptoms and, a lot of severe mast cell activation can be very hard to onboard to HRT. It can be done. It just, you really have to manage both simultaneously. And that's like, you really need an expert to do that. But you can also have excellently optimized HRT and have a horrible lifestyle. And I think it's only doing you a little bit of favor.
Yeah.
So it's really a both and our hope in my practice is really like give the woman back a little resilience, give her back some of her stamina because it's going to help her, number one, to sleep better. I mean, it also, estrogen has an impact on our oxygenation and our airway health, right? And collagen formation.
So many different things. I mean, of course, in the cardiovascular realm, decreasing cardiovascular risk. We're talking about a study I just read today that was looking at a mouse or a rat model and showing that estrogen actually affects the vasomotor tone to specific areas of the brain. So you're talking about personality shifts and things like that. I mean, there's less blood going to certain parts of the brain depending on where you're
and any listener who doesn't know Lisa Mosconi's work, she's doing such incredible work in the area of cognition and the role of estrogen. And we're like just at the beginning really of that research because there's still a black box warning on all estrogen products that say can cause Alzheimer's, can cause VTE, which is not true of transdermal estrogen methodology.
Venous thromboembolism, blood clots for
yes. And so it's really important too, if you're out there trying to advocate for yourself, to be aware that like the pharmacy may say, oh, hey, this person like shouldn't go on this vaginal estrogen or this estrogen patch because they have a history of a blood clot. We have started people on estrogen who have an active DVT. It is not contraindicated. You can do that. You can start them on transdermal estrogen because it does not go by first pass. It does not increase clotting factors, right? And it probably is going to make them feel better. To kind of go back to a few of the positive benefits of estrogen, just for the sort of cardiology nerds. And also, I just want to say a side note that I have said to numerous colleagues and friends of mine that there is not a good medical provider who is not also humble. So I love the way that you describe being curious in your medicine practice. And I love the name of the podcast. So I think that's wonderful.
Well, thank you.
But some of the things that estrogen does, right, is it promotes nitric oxide. I mean, we're talking about nitric oxide in so many realms of integrative medicine and ways to improve nitric oxide production. That's exactly like what happens when you use vaginal estrogen, right? Is it increases nitric oxide in the vaginal tissue and improves vascularity, collagen production. It's, really quite amazing.
And that becomes important not just for sexual drive and things, but also frequent UTIs and anatomic issues with the loss of moisture in the vaginal mucosa. I mean, these are not just, I hate to call it like a vanity type issue, but it's actual medical.
No, it's not a vanity issue. Yeah. And if looking into Rachel Rubin's work is really important here. She's a urologist who has done a lot of research and published a lot on the cost savings to Medicare that would occur if we put every woman over 50 on vaginal estrogen in terms of complications from UTIs. Because as you know, it's like one of the first things we learn when we're in medical training is the cost of UTIs, especially for women inpatient, and what happens because they don't present with UTI symptoms. They present with delirium and it's brushed off and then they get sepsis and then they die.
Or chronic colonization and the vaginal microbiome kind of altering over time.
All of it. Vaginal estrogen can fix that. Right. So at the very minimum, even if you're a person who doesn't want to do HRT, considering some kind of vaginal estrogen product is a really, really good idea. Estrogen increases insulin sensitivity. So like at baseline, that also I think just changes the way that people feel because when you're less insulin sensitive, right, you tend to have more food noise, tend to not feel full after meals.
Like
you're more fatigued.
Food coma afterwards.
Totally. All of those things.
It's like it's a wild ride kind of.
100%.
Think of Kramer from Seinfeld.
The other thing is like there's a lot of good data on how it improves like thickening of arteries. So just like from a very, very, very basic standpoint, from a physiologic standpoint, the presence of estrogen maintains that tensile nature of blood vessels, right? And it helps to promote healing. It's anti-inflammatory, right? A lot of people think about like the reason that we get clots is just because we eat too much saturated fat and we have clots and then they just accumulate in the blood vessel. But it really starts with these sort of microabrasions, right? And the ability to heal those without sort of the stiffening of the artery, right, worsens that pathology.
Yeah, no, And when you think about the number of cells in men and women both that have hormone receptors, or particularly estrogen,
every cell but the red blood cell.
Every cell but the red blood cell. So what does that mean? Estrogen has an effect in every cell but the red blood cell. And I'd say even the red blood cell gets secondary benefits to good estrogen, right? Because of vascular health. So it's still implicated in a kind of a cross, a drive-by kind of way, but there's still benefits to estrogen. One of the things that it came up on a podcast before that I was on, and I never really thought about it is, do you find that some women brag about not needing hormone replacement therapy, right? I called it menopause machismo, because my point was, if there's so much cardiovascular benefit, right, and we really want to be preventative, why are we waiting till somebody has symptoms of menopause to really put them on there? I like what you said, is that every woman after age, 45 or 50, whatever it was that you said, should be on there, because we're not just treating symptoms with this, right? But as we talk about health span and lifespan and optimization, this is, and I didn't know about the nitric oxide association, which is super interesting to me, but because nitric oxide levels being associated with so many things, cardiovascular health, brain health, organ health, kidney, all these things, should we consider hormone replacement as a health span / longevity therapy, not just oh my gosh, it gets so hot I have to turn the temperature down to 50 degrees in my house therapy?
Yeah, well, let me ask you a question. Do you think that we should never screen people for thyroid issues, and we should only screen people who come in and complain of low thyroid symptoms?
Yeah, I mean that.
Or do you think that it's important to test a thyroid panel on everyone as part of your annual workup?
Yeah, no, I mean, that's exactly the point, right? Is that when you look at population-based statistics, when do we screen, right? We screen when...
Well, there's no guidelines for that.
But my point being is that it makes sense to screen when we have a high enough incidence of condition XYZ in a population that goes undiagnosed that it could lead to worse outcomes. I mean, right now, there's this huge push to move colonoscopy age to less than 45 years of age. I mean, in the once upon a time days when I was in med school, I think it was 60, then it became 50, and then it became 45, and now they're thinking of moving down to 40. Nobody feels like I've had friends my age that had colon cancer, and they didn't have severe intractable abdominal pain.
It's really rising in younger populations.
But incidence and the consequence is so high, right, that they've moved that colonoscopy age and they're thinking of getting it even sooner. So to your point, you might not feel bad, but we know that what percentage of women go through menopause? I would assume anybody. Exactly.
And I think,
so you have a potential incidence of 100%.
Yes.
Yeah.
So
I think
have completely my whole frame of mind on how to, because in the medical model, none of this makes sense, right? And everything needs to be tested and proven in so many different ways before it becomes practice. I mean, the Menopause Society says it could be considered for prevention in cardiovascular disease, but still should be really just used for symptoms. And there's only 5 approved approved FDA, Menopause Society FDA approved reasons to use hormone therapy: premature ovarian insufficiency, meaning menopause before age 40, prevention of osteoporosis, or treatment of osteoporosis. However, guidelines don't recommend DEXA scanning until the age of 65, which is far too late, right? And also past that 10-year critical window, which we know is so important, meaning we can still initiate hormone therapy after 10 years post-menopause, but it should be case by case, really evaluated. It's most effective in all the literature when started early, right? In my opinion, in perimenopause, before menopause even occurs. But the other indications are vasomotor symptoms, so hot flashes, which not everyone experiences, although if you do, it's generally an indication that you have more metabolic inflammation, right? It's a concerning thing. So if you have hot flashes, you really do need to be looking at metabolic picture. And when we work up women, we always do a complete workup, because menopause is a multi-systemic disease. It's not just about your hormones and about hot flashes and genitourinary syndrome of menopause. But the things that are not on there are mood, energy, libido, none of the things that people are actually feeling, right, are indications.
Well, that's what I was going to say. It's the things that you actually suffer from on a daily basis, right?
But it's so confusing, right? Because then women are left with this place where they still are conceptualizing menopause as something to be treated when you feel awful. And that was how we were taught in school, was, for less than 5 years, the lowest effective dose, and just to relieve vasomotor symptoms. And so really my whole frame of mind around it was, it's this natural process. Some people have severe symptoms, and it was kind of because they, have a bad lifestyle, so they have really bad symptoms. So I guess help them, throw them a bone. SSRIs were the number one first treatment line when I was in school, which is just horrific if you ask me. But I think about this in this way. We know that ovarian senescence is always occurring, meaning like cellular death in the ovaries, right? We know that people conceptualize this as like, okay, after 35, it's harder to get pregnant, right? But every year, really from the time that you're menstruating, you're losing follicles every year. It's just that there's a huge fall off after 35 that grows exponentially every year. So as your cells are dying and aging rapidly in your ovaries, you're experiencing relative hormone insufficiency. And that hormone insufficiency may show up with slight weight gain. It might show up with, peeing in the middle of the night. It might show up with like more irritability or increasing PMS. But all of these things look like other things. And all of these things can be accelerated by poor thyroid numbers. It can be accelerated by poor blood sugar. All of the lifestyle stuff matters because it will accelerate ovarian aging, right? So the more oxidative stress that you have in the body, the faster your ovaries are going to age. For a woman who's between 35 and 40, most of the time, not all of the time, but most of the time, we're especially leaning into all of those other factors that are going to extend ovarian lifespan and improve ovarian hormone secretion, right? But we also really want to see like, what are your numbers actually doing? And this is why most physicians and practitioners are like hormones, and they just kind of put their hands up and like back away, because they will say, people are told this every day in doctors' offices, well, we don't really test hormones because they change so much. Okay, well, so does cortisol. There are many things that change.
So does blood pressure. So does an EKG.
Exactly. So does blood sugar. And what do we have? We have continuous glucose monitors, right? Like, it is still important to use your brain, right? Most of the time, like women are still cycling relatively every 28 days. There are methods, there are home hormone kits that are, not, the correlation with serum is still sort of questionable, but they can show you the pattern of someone's cycle, the Mira monitor, the Anita monitor, and you can see one of the most important elements of a healthy cycle is that a couple of days before ovulation, say in a 28-day cycle, it may be on day 12, your estradiol will peak to the highest level of the whole cycle, peaks once. And then again in the mid-luteal phase, but not quite as high as right before ovulation. But for many women in perimenopause, that amplitude leading up to ovulation is really crappy. And so then they end up kind of, the FSH in the brain is like, it knows that it didn't hit that point. And so it's secreting extra FSH. And then you get kind of a bigger peak in the luteal phase. So you might test someone's hormones on day 21, 7 days before their cycle, and their estrogen's like 200 or 170. And you go, oh, she's perfect. Her progesterone's 8, which isn't great, but it's there. She ovulated. You're fine. There's nothing wrong with you. Meanwhile, she has poor sleep, increasing anxiety, increased LDL, because she still has estrogen deficiency syndrome. It's just not showing up on day 21.
Because it's taking so much of the stimulating hormone.
Yes. Because she's got so much, she's got this sort of relative estrogen dominance in the second half of the cycle, but she's not getting the amplitude in the first half. So she's having these low estrogen sequelae in the body, and no one's catching it.
So is it like similar, I guess, and I'd have to go back to my endocrinology textbooks to kind of
look at
this,
help.
but it probably won't. But that's more of a Sanjay brain issue than a textbook issue. But like when we talk about blood sugar, checking a hemoglobin A1C, a blood sugar is only half of the story, because you have to look at insulin level as well. I call it the grandma problem. As my grandma was getting older, she was losing her hearing, so we'd have to yell in her ear really loud for her brain to be able to perceive what we were saying. Now, unfortunately, it turned out to be earwax. We got her ears cleaned. It was okay. And that went on for years. I mean, it's like all my family are doctors. It's like the embarrassment of our family. But the point being is that nobody would say that she had normal hearing because we had to, the auditory cue had to be so much louder in volume. So is that similarly kind of what you're talking about here, is that the hormone level to get the stimulating hormone level to get the same estrogen level effect goes up precipitously. And so that's
but you may not see it in FSH. Like you may not catch an FSH that's really high. Again, because everything's fluctuating all the time. So it's really like when you're evaluating hormones in perimenopause in particular, you, in my opinion, in order to really get the best picture, you need two things. You need comprehensive labs. So this is where like the functional medicine is so helpful. And I think the combination of like precision hormones and functional medicine is great, because you're looking at things like vitamin D, which tends to drop in perimenopause. You're looking at LDL, you're looking at ApoB, and all of these things that are going to start to shift and change. You're looking at CRP.
Why don't we just run through? What are the labs? So if we have listeners out there and they're saying, you know what, I'm in perimenopause, and now we have ways that they can go direct to consumer and get labs. Like, there's all these new things. So what are the essential? It would be nice if we had it, but the essential blood tests that you think someone who thinks they're in perimenopause should ask their doctor for, or to seek out on their own?
Yeah, it's a great question. So I think from a basic micronutrient perspective, B12 and folate are super important. B12 is often low, especially if you're protein deficient or if you've been a vegetarian. Iron and ferritin for sure, vitamin D, maybe some other Bs, but I would say those are the essential ones. You could do an omega-3 to 6 ratio if you're like really getting fancy, just because we want to think about like, what is there other pro-inflammatory stuff going on?
What is the metabolic milieu?
Exactly.
Kind of a deal?
Yeah. And then, you want your cholesterol panel, but I also like to have like ApoB, and I think it's depending on the person, of course, there's like consent here, but like, I think it's interesting to know your sort of ApoE like type. And if you carry the genetics for that, just because we're also focusing so much on protein for women in midlife that we want to be smart about what type of protein we're recommending and saturated fats.
And as you were talking about before, how keto works for some and not for others, that's really an ApoE mediated
100%.
phenomenon, right? So if you have the ApoE4 allele, which I think Chris Helmsworth, right, was the celebrity that found out that he had the pre-Alzheimer's gene. He found out on like live TV or something. So that's, I always talk, one size does not fit all when it comes to diet. We do have these kind of nutrigenomics and all the things. All right. So anyway,
so HSCRP. HSCRP for sure. Homocysteine. So we'd like that to be, below 8 or 9 at the, bare minimum, which kind of tells us a little bit about B12 sufficiency and inflammation. Also, of course, a CBC and a CMP. We also just have been running amylase and lipase on everyone because so many people are either on GLP-1s or thinking about GLP-1s, and we just kind of want to know like what's going on with the pancreas. Fasting insulin, obviously your A1C, fasting glucose, which will be a part of your CMP, of course. And then we're looking at usually doing day 21 serum labs. So we're looking at progesterone, estradiol, estrone, which will often favor in perimenopause and menopause because estrone is converted from estradiol, especially in the presence of inflammation, metabolic inflammation, but it's also the primary estrogen secreted by adipose tissue. So if you're having more fat distribution,
peripheral aromatization and things like that.
Exactly.
Gotcha.
I try not to like live or die by estrone because some people just tend to make more estrone. Even people who have like had mold exposure in the distant past, but like now look really good, still might favor estrone. It's really interesting. I don't know how that remodeling happens, but it's just still interesting to look at progesterone, FSH, and LH. And then we really want to see a full thyroid panel. So TSH, total T4 and T3, and free T3 and T4, reverse T3, which will often be really high in the presence of metabolic inflammation or just someone who's extremely stressed, and can kind of give us this pseudo low thyroid picture. But we especially want to optimize T3 because it helps you to respond better to progesterone therapy if your T3 is above 3 to 3.2. And we see that it like has a huge impact on LDL.
Wait, so do you mean that hormones work together?
It's crazy. It's this weird symphony.
It's not just one and done.
It's crazy. It really is and everything is this feedback loop, right? So you pull one lever and you see this, and a lot of this stuff I've just learned literally like working with hundreds of patients, and we sit with them for so long, right? We have hour-long visits and we do so many labs. So you just learn and you find these associations, these things that are, happening. We also really we don't always check this, but I do appreciate LabCorp has a whole blood histamine, which I think is such an interesting measure. So if somebody,
particularly now as we talk about mast cells and MCAS and all these things,
and it's a really interesting place because I think in the last few years post-COVID, there's so many people that have mast cell activation and don't even realize it. And a predominant way that it shows up is anxiety, fast heart rate. Like these women are going to the ER with thinking that they're having an anxiety attack or a heart issue. They even get put on beta blockers and they have mast cell activation. And they tend to be really challenging to onboard to hormones. And it just takes like a very delicate hand. And oftentimes we want to really modulate the MCAS before we onboard estrogen because estrogen can be, even though it's an immunomodulator that's very powerful, the interesting thing about hormones is that like timing and dose matter a lot. So like for some people, especially in perimenopause, a low dose static approach, like you would see with a patch or even a transdermal, cream method, if it's given like low dose static all the time, same dose, it can actually make people feel worse because it sort of reverse suppresses your own FSH, especially the continuous methods like patch where there's no break. And so it shuts down your HPO axis and can actually kind of bring you to like a lower, almost like a bioidentical birth control state is what I find. So I tend to like creams that have breaks between them for women in perimenopause because it kind of allows their own FSH to still participate in the process.
Yeah.
But I got off track a little bit. But the full thyroid panel, and definitely Hashimoto's antibodies. Those are really important to check because...
So what do you like, anti-TPO?
Yeah, and anti-thyroglobulin because so many women have new onset Hashimoto's post-pregnancy, big hormonal shift, and during perimenopause, big hormonal shift, right? When you lose estrogen, you lose that immunomodulation. And so whatever was sort of dampening autoimmune activity, that goes away. And so someone may be feeling all these symptoms of perimenopause And yes, there's some hormonal piece going on, but really they have raging Hashimoto's, and we need to take a Hashimoto's approach with them concomitantly to onboarding with hormones. And this is the part that, like, I love all the attention that perimenopause and menopause are getting. I think it's wonderful. And I think that people are so eager to find like the one trick, the one thing that's going to fix things. And we have a very sick population of people. We know that 60 to 80% of people are metabolically unwell going into perimenopause. And so they have a lot of things that need to be addressed. Just pouring hormones on it is not going to solve the problem.
And that was the point from before, right? Is you have to get as much as you can, everything else in balance. You know, you're talking about the cyclic nature of hormones and how you get worse outcomes with kind of this chronic tonic deployment. And it made me think of, actually, of all things, left ventricular assist device patients. So in the cardiac universe, we have these fake hearts called left ventricular assist device, made famous on Grey's Anatomy season 1. One of them was one of the interns was dating the heart guy, and they cut his drive line so that he could get a heart transplant. My wife told me about that, and I was like, and I was in cardiology fellowship at the time, I think, and I'm like, oh my God, this is such nonsense. Anyway,
you can't watch that show if you're in medicine. It's so painful.
You can't watch that, right? But it's like lawyers can't watch Law and Order probably, and all the things, right? Except the Pit is really good, but that's a whole other podcast. And what we saw is there's two versions of these pumps. There's a continuous flow pump, so it kind of took over your hearts, but it was a continuous flow through. You didn't have a pulse or anything like that. And then there was
didn't have a pulse at all.
You didn't have a pulse because it was just a continuous flow, right? And most of these people have EF, ejection fractions of like 5 or 10. They're on a heart transplant list, so they're just kind of getting continuous flow through. And then some of the LVADs had pulsatile flow, so it mimicked kind of a heartbeat, so you could feel a pulse. And people who had the continuous flow, meaning they did not have the pulsatile, actually had worse brain outcomes and worse outcomes in general. So there's something about, you know, as I'm the curious guy, right? Like there's something about these rhythms of life and these cycles of life that are so important. And you know, probably a lot of people don't realize that men actually have hormonal cycles as well. They're just on a much shorter time frame, right? Like when we look at testosterone, it's a 24-hour time frame, or you look at circadian rhythms. And that's why, you know, I think as you get older, even something as simple as daylight savings that pushes your rhythms back an hour or two, you just feel it so much more because your body has, in a sense, as you mentioned, cellular aging, probably lost a lot of that cellular resilience to be able to just shift, right? And why like third shift workers have such a hard time, night shift people in the healthcare universe and otherwise, like
dramatically higher
pilots or people in the airline industry, flight attendants are going from time to, it's just bonkers.
Yeah, I mean, the most basic, simple things are the most helpful. And, you know, we do live in rhythm, and the hormonal cycle itself is this infradian rhythm, right? And it is really important. And we don't have enough data yet, but we are starting to experiment with, like, if we reproduce that infradian rhythm and we keep the cycle going in that sort of same way that it functions naturally, like, do people have better outcomes versus a static approach even into menopause once like the cycle has stopped? What if you continue the cycle? What if you keep someone menstruating so that you get that peak of estrogen? Does that have different outcomes? And I think it's going to be really interesting to see that research come through.
I mean, you know, I'm married, I'm a girl dad, and like women just fascinate me. Like, how do you exist? I know
we are here to see the world through many different lenses.
I mean, I feel so guilty as a guy because I'm like, man, my life is pretty easy, right? Like, I mean, like seeing, you know, I mean, I never had a first period, but I had 3 of them through my daughters, and like explaining what was going to happen. And then they're like, this is going to happen every month. And it was the gravity of telling my then 9 or 10 or 11, I don't remember, year-old daughter, it's going to happen every month. Like, I'm like, what the actual F? Like, you have to do this that many times. Like, this is like, and I mean, it's just, I don't know.
Well, and I think that we really
shout out to the XX chromosome people out there. I mean,
we are definitely a cool species, but I think that we miss an opportunity to really educate girls from a young age of like what you gain from being a cycling creature, like how your perspective and your outlook changes under the influence of different brain chemistry, essentially, right? That like in your progesterone time, you're more introspective. Like that's a good time to sort of wrap things up. And I mean, it's really fascinating. You could like go down a deep dive on, you know, Instagram of like people who sync their life with their cycle and their activities and like their business structure. And I just think it's fascinating. And it's like stuff we withhold from people. They don't know about that.
Well, and is it so much withholding or just research hasn't really been done? Right. I mean, I think there's a lot of when you look at the healthcare dollars, and cardiovascular is a huge, offender in this, but, up until a few years ago, most studies were like 80% men.
Oh, for sure. And we only started doing research on
and
women in the very last part of the 20th century.
Yeah.
So there's that. But I also think that we, in medicine, we're really averse to woo. And so if anything gets too qualitative and kind of too like, I don't have bench science to back this up, and it's like how you feel, it's like we just don't want to go there. I mean, it's why like a lot of childbirth research, like, just hasn't been, it's like this, but this is just the obvious stuff,
it just seems, it seems too soft or too weird.
100%. Yeah. And you know how Socratic and how like, dogmatic medicine is. It's like, if you don't have, how it is. It's like,
Emily, you're talking to a cardiologist.
I know. So it's like, you show up to rounds and like you say something that's like
in the IBIS 2 trial from 1973,
totally.
What were the results and the things? I'm like, 1973, that was like 1,000 years ago. Like,
totally.
And so, and one of the things that I learned, maybe probably more in the functional mindset than the conventional, is lack of evidence doesn't mean lack of efficacy,
100%,
right?
Yeah.
And also, one of the truest things ever is population-based statistics don't affect an individual. Meaning, like in the clinical trials of cardiovascular drugs, an 11.7 versus a 9.2% event rate or whatever it is, you don't have a 9.2% heart attack. It's binary. You have a heart attack or don't.
Yeah.
And so I think part of the rigidity, I mean, that as being kind of curious all my life, but part of the rigidity that always just frustrated me was exactly what you're saying. It's an all or none phenomenon, when even the literature doesn't show that anything is an all or none phenomenon. There's never in my read of literature been a study that had a 100% event rate in a placebo group and a 0% event rate in the study group, right? So we have to individualize therapies, right? I mean, just in the same way that now when you look at chemotherapy, it's being much more individualized. They take a biopsy of the tumor and look at molecular markers and
the genomics.
And the genomics of all these things, right? Like nobody would ever say, well, let's just go back to the old days where you kill off every cell and hope that you get more bad cells and good cells. I mean, we are moving towards this much more precision model. And I think, we think of this as highfalutin, but it is so frontline when it comes to menopause therapy.
Yeah. Yeah, really, I think the most relieving part of functional medicine to me, even though I've left a lot of the functional medicine behind, I didn't really get to this part in my story, but when I first started practicing functional medicine, it was like, geez, all these women in their 40s and 50s are only getting like 10% better on an elimination diet. Like their husbands will do the elimination diet and lose 30 pounds. And these women are like, nothing's happening. But like, that's not what I was taught in IFM. I was taught it was like the gold standard. Like you put everybody on, this diet and like they're supposed to get 100% better, but like their autoimmune markers are getting worse because they're just stressed and they've lost stress resilience. But so that aside, I do think that that's like the pitfall of functional medicine right now, is that it's still so focused on a male-centric model and it's missing this piece. But the benefit of it was that it really allowed me to have the permission to do these N of 1 studies on people. Because I already had familiarity with like very intimate care coming from birth and having home births myself and like training in that space where we had hour-long visits. And I understood that like knowing that person, knowing like what made them tick, what made them feel fear, what made them feel safe, like that could impact an outcome. And like watching how when one person would storm in the room and make a woman feel fear, like how this cascade of events would unfold because her nervous system was dysregulated in labor. Interestingly, to wrap up our estrogen benefits, estrogen is a massive regulator for the vagus nerve. So when we lose estrogen, we lose vagal tone, meaning that we cannot bounce back to parasympathetic as easily. So the way that this shows up is like a woman in perimenopause, I have a 4-year-old. Her 4-year-old like knocks a glass on the floor and it shatters, right? So of course, like you're going to have some amount of upregulation from that, but usually you clean up the glass, you throw it away, you're fine. A woman who's lost her vagal tone, like can't shake the feeling of anxiety for hours, even though she knows cognitively that it's like not upsetting. It's that like physiologic feeling that she can't regulate back to a parasympathetic state. And that's something that I feel like women get gaslit about a lot, is like if they're complaining that they're kind of always feeling like they're in this upregulated state. Even functional medicine people will be like, what are you doing? How much are you meditating? Like, are you doing your yoga? Are you doing your walks, your grounding? And all that stuff is helpful. But so many women, as soon as you apply some kind of transdermal estrogen therapy, it's like the sky opens up. It's like they're just like, whoa. Right? Because they can regulate their vagus nerve. They can also make,
Yeah.
serotonin, norepinephrine, epinephrine, dopamine, like all of these things. The precursor for that is estrogen.
Wow. I mean, so fascinating, all these different effects. I would never have thought that. And as a husband, I'm trying to figure out a way to politely suggest maybe we should look at an estrogen level sometimes when my wife freaks out at me. I don't know if that's the political right thing to say or not here.
The next time we're in California, we'll
back?
have a couples dinner, and I'm sure we'll get there in the conversation.
Again, I don't know how women exist, or if, like, you guys are like separate creatures on different planes than we are. I mean, even just having a baby, bringing something from the metaphysical world into the physical, your portals into different dimensions and all these different things. I mean, it's just the spirituality of the feminine is just mind blowing to me. And guys, all we have to do is show up, right? Lift heavy things. I mean, that's the extent to which I contribute to the existence.
No, but we need that masculine energy too,
I guess. The yin and the yang. But, super interesting. I mean, I feel like, as with all my conversations, on the Curious Cardiologist podcast, and I mean this in the best possible way, like, I didn't realize how stupid I was until we had this conversation, right? But that's the important part of being curious, is really kind of looking at things that you thought you knew through a completely different lens. And man, now I have to go back and look at all these women that I treat, and not just because I'm a cardiologist, but probably because I'm one of the few people maybe in tune to what's going on, right? A lot of people are just out of touch with these sorts of things, and really getting women the proper therapy that they need. So, Emily, thank you for opening my eyes to this. It's like the most obvious thing that is so not obvious in medicine, right? Is that, hey, you know what? Estrogen matters. Maybe that's a t-shirt we need to make. Estrogen matters.
That's a book, actually, by Abram Blooming.
Is it really?
It's a fabulous book written by a physician whose wife had breast cancer, and it really made him question, the sort of blanket advice that you can't have estrogen after breast cancer. It's actually one of the most well-written books about estrogen in general and all of the benefits. So I highly recommend that you read it.
All right,
if your providers read it.
There are no new ideas under the sun. That was already taken. But let me take I'll take a read of that book, because as a cardiologist, I can tell you, in 4 years of cardiovascular research and training, estrogen was maybe mentioned 0 times.
Yeah. And probably just as a risk factor for VTE.
And it wasn't, like we were talking about, maybe it was early periods or late periods or something, but certainly not. But listen, certainly not at a molecular level that we're talking about here.
The research is fascinating, because we know that women who menstruate later and go through menopause earlier have a higher risk of dying from a cardiovascular incident, right? Because the collective protection.
Their time of exposure,
and even like
estrogen,
the more pregnancies that you've had, the more protection you get, because you get these giant boluses of estrogen exposure, right? Estrogen in the thousands, the levels in the thousands. It's just fascinating. And from a breast cancer perspective too, if you have a pregnancy before age 20, I think it is, or maybe 18, you've almost a 0% risk of getting breast cancer. So there is something about those peak levels of estrogen that upregulate stem cell production, that are massively anti-inflammatory, that probably set up the milieu for cardiovascular, metabolic health and inflammation, like from a very early point, right? It's really fascinating.
I mean, from an anthropologic level, maybe if you have tons of kids, nature needs to make sure that you're around to raise them as a woman, right? And
I love that.
Oh my gosh, we can think of so many different things. Oh my gosh, Emily, gosh, I feel like I need to have you on. We need to do like a masterclass or a summit in this.
Yeah, no, for sure. Like we should also talk, I think, for your people, like, we should talk about, real doses and stuff. And like, how do you actually, what's the most basic, easy way to start? I have a great osteopath who said to me, like, I'm just realizing the connection between musculoskeletal issues and menopause. I'm going to start putting women on birth control. And I was like, we can do better than that. We can do better. I will teach you.
For whatever reason in my brain, and correct me if I'm wrong, I have like 0.25 to 0.5 transdermal of estrogen and 100 oral of progesterone. Is that a good place to start?
To be honest with you, I never start any woman on less than 0.05 milligrams of estradiol from a patch perspective. I just think it's like a pretty useless dose and works for almost no one. Yeah. So that would be if you are like just trying to do the easiest thing for a menopausal woman who's not cycling.
If you're a cardiologist, trying not to kill somebody practicing outside of your scope.
You will not kill anybody. Like, it's one of the hardest things to kill someone with is transdermal estrogen. But you could do 0.05 and 100 milligrams of progesterone. Super easy from any pharmacy. And that's like a very basic, and you're going to do some good with that.
Yeah. And then vaginal versus like oral.
So vaginal is if you're doing, a traditional commercial dosing, everyone needs vaginal as well. So you can do, an estrase cream, like a commercial, product. You can get compounded formulas if people are sensitive. Some people will just be sensitive to estrase, but vaginal estrogen doesn't breast cancer, like people who have active breast cancer can take vaginal estrogen, right?
So it's more of a local phenomenon, not as much systemic.
Does not affect systemic circulation.
All right.
But then on top of that, you would also need your systemic estrogen.
Okay.
I really tried to get people, if we're doing a static, low dose, non-complicated, non-precision approach, to at least a serum estradiol of about 80. That seems to be suggestive of like protection from osteoporosis. And I feel like if we're to 100. If we're doing that, then we're probably protecting other organ systems. Again, we don't have enough data to support it. But most importantly, like you're going to start to see the changes in their health. But there are other like more advanced, regimens that can work for people who are in really severe places.
As you're talking, Emily, I'm like, you've forgotten more about hormones than I'll ever know. So how do people find you? I've got, my listeners, like I want to send my wife over. I mean, my daughters, I want to send them over. Like, I mean, any woman I know, I want to send over to you. So how do people find you?
Thank you. Yeah. So you can find me on Instagram, Emily Sadri _NP. You can also follow my clinical practice. My telehealth practice is called Aurelia Health, or our Instagram is @Aurelia Women's Health. And we serve 12 states, which we'll list in the show notes. And you can go to aureliahealth.com. You can work with us. Our programs are 7 months long, and then people can remain a patient forever. We like to call ourselves primary hormone care providers because you really do need that whole picture primary hormone care, I think, from perimenopause and beyond. But you can also just come and get a big panel of labs and a 1-hour consult with us if you want a second opinion, or you're curious of where you are in perimenopause. Is it related to your lipids? Is it related to your, inflammation? We can decode all of that for you.
All right. Well, I end the podcast always with 3 rapid fire questions that oftentimes are the most interesting questions I ask on the podcast. Number 1, where's your favorite place on earth? Somewhere that you've been where you're like, I could live here forever.
Well, we love the southwest coast of Michigan.
Southwest coast. Oh, okay. But like Benton Harbor, kind of over there?
A little bit further south than that. But we just sort of accidentally started going there for vacation. And when we moved to the Midwest, and we love it. I would say like that my favorite place that I've ever been to would be the Isle of Skye in Scotland. I don't know if I could live there though, because it's quite isolated. I'm very social.
I think it's weird because I actually grew up in Northwest Indiana. So that little corridor is like right next to us of that Southwest Michigan corner. Number 2, what's your favorite food? Healthy or unhealthy? It doesn't have to be kale and, locally sourced carrots. Like I had someone say Chicago deep dish pizza. And I'm a Chicago guy.
My favorite comfort food is this is siete corn chips, not the cassava ones, but the corn chips.
Just actual corn chips.
By Siete, like the healthy ones. But
the
company Siete, which is a healthier kind of good oils and all that stuff. But those corn chips, I would take over any treat any day. They're my favorite thing ever.
Just all the time. As we say with my dog, high value treats. He's got his high value treats. So that's Emily's high value treat. And then finally, what keeps you curious? What do you love to learn about? What is a book or a series of subject that you could just read forever?
I think that actually the book that got me into this to begin with was The Red Tent by Anita Dumont. It's all about sort of birthing in biblical times and, how women would go off to the red tent when they were menstruating. And I'm always so fascinated in the position of the matriarch, the role of the woman. I think why I still love what I do today is because when you make women stronger, you affect families, communities, like everyone benefits when women are healthy and strong. And so just like that sort of brand of feminism is fascinating to me.
Love it. Absolutely love it. Thank you, Emily, so much for being here. Like I said, I love at the end of these podcasts where I'm just like head scratching. I'm like, boy, I had like none of this in my brain yet. So, but that's the power of the podcast and the episodes and the guests that we have like you that just open up my eyes to new things and our listeners get to learn things in a new way. So thank you so much for being here with me today.
Thank you so much for having me. It really was a real pleasure.
And thank you guys for taking the time to listen to this episode of the Curious Cardiologist podcast, where we're always looking to look at old problems in new ways. And today was a great example. If you like what you heard, please make sure to subscribe to the podcast. We're releasing episodes twice a month and increasing from there and just bringing more fascination to your life. And if you resonated with something that we talked about, or you said, Sanjay, what you said, that made absolutely no sense. You're an idiot. Leave a comment. Let me know. I scan the comments. I love interacting with you guys, the audience. And if you have suggestions as to something that you want me to explore, I'll be happy to take that as well. So thank you guys for being here. Emily, again, thank you for being here. And we'll catch you on the next episode of the Curious Cardiologist podcast. Bye, everybody.